Hello everyone, this is Mrs. Korea. Welcome to week 11 lecture. The topics included for this week are caring for a child with immunological and infectious conditions. They are measles, mumps, rubella, fifth disease and infectious mononucleosis, and caring for children with cardiac conditions. Under that list cyanotic and acyanotic heart defects, ventricular septal defect, patent ductus arteriosus, coarctation of aorta, and tetralogy of Fallot. And there are so many conditions under these systems, but for the purpose of the class and for the exam, we are going to focus on these topics only. Infectious diseases. Let us start with pertussis. Pertussis is otherwise known as whooping cough, and this is bacterial. And this is caused by Bordetella pertussis and occurs in an unimmunized or partially immunized children. And the signs and symptoms are mild respiratory distress with the classic whooping sound. Persistent dry cough may last for months and includes coughing paroxysms and vomiting after coughing. Nursing care includes administer antibiotics. Usually the azithromycin is used as an antibiotic. Maintain airway and monitor oxygen saturation. Pertussis complications are apnea, seizure, severe pneumonia, encephalopathy, epistaxis, and even death. For the purpose of this class and exams, we are going to focus on what is the causative agent for all these conditions under each systems, and also the signs and symptoms, care, and the main complications. We are not going to focus on the pathophysiology because we are unable to cover everything in this class. So most questions will come from causative organisms, signs and symptoms, care, and the main complications. Measles, otherwise known as rubeola, caused by morbilli virus, transmitted by droplets, infectious secretions like blood, urine, and vomitus. Incubation period is 8 to 12 days. Signs and symptoms are moderate fever, cough, coryza, and conjunctivitis. Then Koplik spots, this is very characteristic feature of measles. They are blue-white granules on erythematous base, which you will see in the oral cavity in measles. But we have to be very careful with this because the Koplik spots usually appears before the rash appears. So people don't get to see the Koplik spots most of the time. Then the rash stage is usually lasts about 3 to 4 days with a rise in fever up to 105 fever. The rash first appears on forehead behind the ears and then spread to face, trunk, and extremities. There will be anorexia, malaise, fatigue, and generalized lymphadenopathy, and photophobia that is not always present. Care is supportive with antipyretics, bed rest, and increased fluids. Complications are pneumonia, otitis media, mastoiditis, encephalitis, and myocarditis. Mumps. Mumps is caused by paramyxovirus transmitted via droplet, and it is most contagious 2 days before symptoms begin to 6 days after they end. The signs and symptoms: malaise, low-grade fever, anorexia, headache, and pain with chewing. And as the disease advances, bilateral or unilateral parotid gland swelling appears. So with parotid gland swelling, you will see one side swelling or both sides swelling, and we have to be careful. Like, it's a practical point that sometimes people may mistake it as a dental infection or vice versa. I remember a case 2 years ago, we all thought it is mumps, but it turned out to be a dental infection. The care include supportive and control of signs and symptoms. Complications are meningitis, photophobia, stiff neck, orchitis. That is the most common complication in post-pubertal men. And less common complications are oophorytis, that is inflammation of the ovaries, pancreatitis, myocarditis, and deafness. Next is rubella. It is otherwise known as German measles or 3-day measles. It is caused by rotavirus. In US, the peak age is 6 months because infants are not vaccinated yet. It is highly contagious, spread through placenta or nasopharyngeal secretions. Incubation period is 14 to 21 days. The signs and symptoms: the rash starts on forehead, face, and spreads over the trunk and extremities during the first day, and the facial exanthem fades by second day and disappears by third day. That is why it is known as 3-day measles. There could be mild fever, sore throat, arthralgia, eye pain, gastrointestinal upset, and lymphadenopathy. Rubella. The care includes supportive care and antipyretics. Isolate child from others up to 1 week after rash appears. Complications: higher risk prenatally in first trimester till 16th week of pregnancy. So if a mother contracts rubella prenatally, especially in the first trimester, the fetus can have mental retardation, deafness, eye disorders, cardiac defects, and stillbirth. The postnatal complications include arthritis, idiopathic thrombocytopenic purpura, and encephalitis. Fifth disease. This is otherwise known as erythema infectiosum, caused by human parvovirus B19. The signs and symptoms are: it begins with facial red rash, appears as though the cheeks are slapped. So we call it just like a slapped cheek appearance. The rash spreads to trunk, extremities, and appearing more as macular, that is flat, lacy appearing erythematous exanthema, and fever may occur. Although usually gone in a week, rash can recur and heat exposure for up to 4 months. The diagnosis is made through clinical appearance of signs and symptoms and can be accurately diagnosed with IgM parvovirus B19 antibodies in serum within 30 days of rash onset. Nursing care: keep child away from pregnant women, because if the pregnant women are exposed to fifth disease, that can cause some congenital problems to the fetus. Use acetaminophen or ibuprofen for symptoms that may accompany the disease, like high fever, sore throat, and headache. Droplet precautions should be instituted if the child is hospitalized. Fifth disease education and discharge instructions include: instruct patient and family to maintain safe hygiene practices. Emphasize keeping child away from potentially pregnant women. Do not use aspirin containing products because of risk of Reye syndrome. Infectious mononucleosis. It is also known as kissing disease. It is caused by Epstein-Barr virus, and historically infectious mononucleosis was first discovered as a disease that was transmitted through kissing. So the reason for calling infectious mononucleosis as kissing disease, one reason is historically it was transmitted through kissing. Another reason is the tonsils of this patient will enlarge so big, so bilaterally, so when both tonsils are really enlarged, it almost touches. So that is called kissing tonsils. So the other reason for calling infectious mononucleosis is because of the kissing tonsils too. Although it can occur at any age, the disease is most commonly found in adolescents and young adults. Signs and symptoms are swollen, enlarged, and tender lymph nodes, cervical and often occipital, tonsillitis or pharyngitis with significant exudate, chills, fever, headache, anorexia, malaise, and spleen may become enlarged initially. And as a practical point, I have seen many patients with infectious mononucleosis with the kissing tonsils, and splenomegaly. And the mononucleosis hepatitis is also possible in severe cases. Diagnosis is positive monospot test or heterophil result is confirmatory. Monospot test may be negative in the early stage of the disease, and the CBC and differential may be useful. Sometimes increase in monocytes seen on differential cells in early stage of the disease, and blood test can be drawn to confirm the presence of Epstein-Barr virus. Nursing care include communicate to the parents the importance of bed rest, but that is not always recommended. Maintain hydration, decreasing fever, isolating patients during acute phase, continuing to include rest periods after acute phase, removing child from contact sports that can injure liver or spleen. You know why? Because there is possibility of splenomegaly or hepatomegaly, and you want to avoid rupture of the spleen especially. So remove child from participating contact sports, and discourage sharing drinking cups, utensils with family members and peers, and close contacts such as kissing should be avoided. Educate about risk of spleen rupture, possibility of relapse with worsening symptoms, avoiding acetaminophen due to greater risk of hepatotoxicity when liver is enlarged, and avoiding alcohol due to risk of hepatomegaly. Cardiac conditions, we can divide them into cyanotic heart defects and acyanotic heart defects. The congenital cyanotic heart defects are transposition of great arteries, tetralogy of Fowler, atrioventricular septal defects such as AV canal defects, endocardial cushion defects, tricuspid atresia, total anomalous pulmonary venous return, truncus arteriosus, and hypoplastic left heart syndrome. The common acyanotic congenital heart defects are ventricular septal defect, that is the most common congenital heart disease, atrial septal defect, patent ductus arteriosus, pulmonary stenosis, aortic stenosis, and coarctation of aorta. Ventricular septal defect. A ventricular septal defect is the most common congenital heart defect. Occurs when the wall between the ventricle chambers does not form completely. When I say this is the most common congenital heart defect, this is also common among genetic disorders such as trisomy 21, trisomy 18, and trisomy 30. And signs and symptoms are mostly asymptomatic, and the large VST with a significant left to right shunt, there could be signs of right ventricular failure, and there could be shortness of breath, feeding difficulties, poor growth, easy fatigability, recurrent pulmonary infections, murmur, a harsh murmur along with thrill at left lower sternal border, and this murmur is usually pansystolic. Diagnosis is based on the audible heart murmur with other signs and symptoms, and tests such as chest radiograph and ECG support diagnosis, and confirmed by echocardiogram, cardiac catheterization, and or cardiac magnetic resonance imaging or MRI. Nursing care is similar to that of atrial septal defect and focus on post-operative management of child, and education and discharge instructions are same as for any cardiac condition in children. Patent ductus arteriosus. This is the simplest form of vessel defect, and the blood is oxygenated through the placenta by the umbilical vein, and the blood moves through the ductus into the aorta and out to the body tissues. And if the period does not close after birth, severe long-term sequelae occur, and that is called patent ductus arteriosus. I want you to refer back to fetal circulation, and remember I told you that the ductus arteriosus closes after birth. So if it is still open, that is called patent, and this is patent ductus arteriosus. The signs and symptoms are PDA murmur, distinctive in sound and location. It is best heard at the subclavicular margin and described as a machine-like to and fro or continuous. So we call it like continuous machinery-like murmur. And the frequent calls, susceptibility to RSV infections, fatigue are the other common signs and symptoms. Other signs and symptoms include poor feeding, poor growth pattern, blood pressure reveals white pulse pressure. I hope you all know what is pulse pressure. And diagnosis is based on the presence of characteristic murmur with symptoms of heart failure. And chest radiograph shows enlarged heart, evidence of excessive blood flow to lungs. Echocardiogram confirms the diagnosis and demonstrating the size of ductus arteriosus. Care include this closure of PDA may be accomplished by surgically closing the PDA with transcatheter devices. Then another method is, if there is a small PDA, you can use indomethacin or indocin to close the PDA. And focus on post-surgical measures, wound care, monitor vital signs, ensure adequate hydration and nutrition, and monitor for signs of migration when transcatheter closure device is used. And the education and discharge instructions include, that is same as the education discharge instructions for cardiac conditions in children. I want you to read it from your textbook. Coarctation of aorta. Coarctation of aorta is a narrowing or stricture of the descending aorta distal to the carotid arteries. Signs and symptoms are murmur, and the murmur is not always present. Systolic ejection murmur heard at upper right sternal border and left sternal border. And the cycle radiates to left axillae and left intrascapular area of the back. There could be signs and symptoms of congestive heart failure, possible pain in legs or cyanotic lower extremities. The diagnosis is based on characteristic high gradient, that is the difference in the pressure between arms and legs. Remember, I talked about this in the clinical, and the blood pressure should be higher in the legs than arms normally. So in coarctation of aorta, you may see lower blood pressure in legs. So whenever there is lower blood pressure on the legs compared to the arms, you should suspect coarctation of aorta. And two other things also I mentioned in the clinical. What are they? One is simultaneously palpating the femoral pulse and the radial pulse. And if there is a difference, and if you find a feeble pulse and lower pulse in the femoral area, then you should suspect coarctation of aorta. Then one more thing is preductal and postductal oxygen saturation. That is usually done on simultaneously oxygen saturation on the right hand and right foot. And if there is low oxygen saturation compared to the hand on the legs, then you should suspect coarctation of aorta. So this became a practice that the AAP recommends now, that to do preductal and postductal oxygen saturation on all newborns before they are discharged from the hospital. The nursing care focus on postoperative management and monitor for evidence of restenosis through proper evaluation of upper and lower blood pressures. We need to control severe rebound hypertension with antihypertensive agents such as captopril or enalapril. Then education and discharge instructions are same as that of cardiac conditions in children. Tetralogy of Fallot. Tetralogy of Fallot is a combination of defect. There are always 4 associated conditions. One is ventricular septal defect, overriding of aorta, hypertrophic right ventricles, and pulmonary stenosis or atresia. This tetralogy of Fallot is a cyanotic heart defect. And the signs and symptoms are tachypnea, dyspnea on exertion, growth failure, cyanosis after ductus arteriosus closes, loud systolic ejection murmur described as harsh and radiating, right ventricular hypertrophy caused by a stenotic vessel, and high pulmonary vascular resistance. Remember, in the fetal life, the pulmonary vascular resistance is high, and after the baby is born, in the newborn period, the pulmonary vascular resistance should drop. But in this condition, there could be high pulmonary vascular resistance, then it can lead to right ventricular hypertrophy. Diagnosis of tetralogy of Fowler is based on signs and symptoms, and the test support and confirmed diagnosis are ECG, echocardiogram, chest X-ray examination, cardiac catheterization, and the nursing care include, that is, care prior to surgery, such like prevent and minimize symptoms associated with defect. After surgery, focus on post-operative management of child. Education and discharge instructions are same as that of children with cardiac conditions. That's all about week 11 lecture, and thank you for listening.